So this is a case of a 54-year-old gentleman who presented to his local hospital with abdominal pain, nausea, vomiting, and was found to have abnormal liver function tests, notably a bilirubin of 6.2, as well as elevated lipase. He underwent an abdominal ultrasound, which showed distended gallbladder with numerous small stones, diffuse wall thickening, and some intrahepatic biliary dilatation. MRCP showed diffuse intra and extrahepatic bile duct dilatation with a maximum common bile duct diameter of 1.4 centimeters, which tapered at the level of the ampulla. However, there was no definitive choledocholithiasis. This gentleman has been referred to IES for EUS plus or minus ERCP. Let's go to the treatment room.
Okay, thank you for the introduction, Patrick. So, this case, while we don't necessarily see stone on imaging, sort of by the ASGE guidelines, he has very high risk for retained choledocholithiasis, in particular, given the bilirubin above 6. So it's fairly standard, even despite that, for us to start with EUS to assess for presence of a stone. In particular, in this patient, as of today, he's actually saying that he has had complete resolution of his pain. So I'm doing EUS here, and I'm going to go straight towards the bile duct. I'm right now in the duodenal bulb. You can see the bile duct, and below it, the portal vein. And just going to run that basically and make sure I get visualization of the entire duct to assess for presence of stone. This actually looks fairly decompressed right now. And I'm not seeing a stone from within this view. So not much in terms of dilation. His bile duct is 5 millimeters now. Just tracing the bile duct back up towards the hilum, we do see sort of a stone basically close to the junction basically of this cystic duct and the bile duct right here, but still nothing within the bile duct itself. And then just scanning over to look at the gallbladder, and here you see cholelithiasis. So to make sure we can definitively clear the bile duct, we'll go back down, actually into the second portion of the duodenum, and look from there, looking closely in the region of the papilla to assess for presence of stone. So now I'm in the second portion, and typically in this position, and we'll introduce some water or saline into the duodenum to help with visualization. Okay, and we'll have one more flush. And here I have the uncinate process of the pancreas sort of to the right of the monitor. And I'm going to be pulling back, looking for the ampulla, the pancreatic duct and the bile duct. Okay, so getting close here. And there I can see the pancreatic duct, the thin ductal structure there. There's some hypoechogenicity above the pancreatic duct at the region of the ampulla with some likely edema or swelling there. But what I'm not actually seeing yet is any kind of stone present or any shadowing. Okay. And then here, I'm starting to see the bile duct. So here I can actually see pretty thin normal tapering of the bile duct right to the level of the ampulla. So I don't see a stone, so I think we'll actually forego ERCP. And this case, I think, is a good demonstration, basically, of sort of the fallibility of the ASGE guidelines still. So it's important to keep in mind that even with the stronger predictors in this setting, or in this case, the bilirubin above 6, only about 45% of the time are stones actually seen at the time of ERCP. So, our standard practice is to do the EUS to clear first to spare potential cases of pancreatitis. So for this patient, of course, I think we'll just stop, and the next step will be cholecystectomy. So I think so this patient, I think, was admitted 2 days ago, or 2 nights ago, basically. So the CT would have been between 36 and 48 hours ago. Okay. Yeah. And here just is a final view, basically. I'm looking transgastric at the area of the porta hepatis, and just one more view transgastric of the common hepatic duct here to further assess for no stones up towards the liver. Within the liver, I'm seeing hepatic steatosis, but no kind of intraductal dilation or stones. I think it, yeah, I think it doesn't look basically distinct like a mass. Here, I can show, can we switch to the endoscopic view? So we'll also show an endoscopic view to kind of further exclude concern for mass. Um, which also looks extraductal, so I can see basically tapering, and then it's the soft tissue around the ampulla where we're seeing a hypoechogenicity, consistent basically with inflammation probably from stone passage. Trying to get a good view of the papillae here. We'll get some of the bile out of the way. Yeah. Uh-huh. And here we have the papillae here, and you can see there is basically erythema, likely from irritation from stone passage right there, but certainly nothing abnormal concerning for ampullary adenoma or other mass. So I think then, we'll finish up the exam here for thoroughness sake, but we can switch over to Dr. Bidmuller's next case, and we'll start with the case presentation for that.